2021 COVID-19 clinical rounds, mass critical care. This is the third in our series. This one will be focused on communication and coordination strategies. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated for these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Struminger and his team for the peer-to-peer learning platform we use for these rounds. Today's critical care rounds is the third of a three-part critical care mini-series. The first addressed system-level strategies for surge capacity. Last Tuesday's addressed staffing and resilience, and today's is focused on communication and coordination. Mass critical care experts for this series are from the Task Force for Mass Critical Care, a scientific organization composed of a diverse collection of disaster preparedness experts from a diverse background in medicine, nursing, pharmacy, respiratory therapy, and other specialists. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS, Tuesdays are critical care, and Thursdays are emergency department rounds. Our HHS Emerging Outpatient Therapeutics series are on Wednesdays, also at noon Eastern time. I'll now turn this over to Dr. Struminger from Project ECHO.
Thank you, Rick, and welcome everyone. Thanks to all our participants who are joining us and taking time out of their super busy schedules. And thanks to the Mass Critical Care Task Force and our expert panelists who join us regularly on Tuesdays. Just going to go over a couple of announcements and logistics quickly. I know the Mass Critical Care team is looking forward to your questions, so please put those in the Q&A feature at the bottom of the Zoom toolbar on the right. If you have any technical or logistic issues, please mention those in the chat and we'll try to help you out as best we can. We are recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. Today's presentations will be shared along with the recording on the Clinical Rounds website, and we will share a link to that in the chat. It should also be on the announcement that went out to you after you registered. We are offering CME and continuing education credits through the University of New Mexico, where Project ECHO is based. We'll share a link to the survey and the instant CE in the chat about 15 minutes before the end of the session. It also should be in the email announcement that went out today from Project ECHO. Just as a reminder, these learning sessions are focused on improving patient care, health systems, and supporting clinicians. Please let's keep them apolitical and non-commercial. Thank you for that. And just a couple of words about data. The data you share with us when you register, when you take the polling questions, when you put questions in the chat, in the Q&A. We just want to remind everyone we take the data stewardship very seriously, and we keep your data confidential. Whatever we share with Rick and Asper is all de-identified. As Rick said, NETEC, the National Emerging Special Pathogen Training and Education Center, is a partner in this educational initiative. They have their own series of webinars, which are terrific, coming up this Friday on the 12th, they'll be doing a session on SARS-CoV-2 mutations and variants. And that's certainly a hot topic right now. So we recommend you try to attend that. If you can't do it live, they do record and archive all their sessions. Also, Rick mentioned the mini series on outpatient therapeutics, currently focused on monoclonal antibodies. Tomorrow's session will be focused on some examples of speed and scale with local community level examples. Also, the AAMC, the Association of American Medical Colleges, is a partner in these rounds. They have a great clinical guidance repository, which they've been maintaining and building since the beginning of the pandemic, and they keep it up to date, adding to it every week. Rick, back to you for the crowdsourcing question.
Thanks. Well, I realize we're going to be focused on communication and coordination strategies. One of the things that as the disease has progressed, our sort of like working knowledge and experience with the disease has progressed as well. And so this one is directed at trying to figure out where we are with the disease at this juncture. Since January 1st, 2021, so since the beginning of the year, are you seeing any new patterns of disease in COVID-19 patients? And a no answer is actually helpful piece of information. So yeah, no is fine. If you are, what is it that you're seeing since the beginning of the year that's different? Again, we all learn through this platform, particularly by not just our presenters and panelists, but our participants really joining in with the dialogue, both in the QA, the chat, and the crowdsourcing question. Yeah, already seeing one response, so really appreciate your joining in. With that, I'm going to get back to the topic at hand, communications and coordination strategies, and turn this over to our moderator, Dr. Jeff Dichter from the Task Force for Mass Critical Care. Jeff.
Thank you, Rick. I'm Jeff Dichter from the University of Minnesota and also one of the executive committee members for the Task Force for Mass Critical Care. Welcome, good morning to everybody, and good afternoon for those on the East Coast. I'd like to introduce our presenters today. Dr. Karen Baum from the University of Minnesota, Dr. Jason Persoff from the University of Colorado, and also a shout out to Dr. Henry Feldman, who will not be a presenter, but part of the executive committee, executive team working on this particular project, and appreciate all three of them. Our panelists who have special expertise for today's presentation include Kathy Statz, MD, who's the Imperial County EMS Medical Director from California, also from Stanford Healthcare, Christy Koenig, who's the EMS Medical Director from the County of San Diego, Patty Maysent, who's the CEO of the University of California, San Diego Health from San Diego, California, of course, and Dr. Steve Mitchell from the University of Washington, who's the Medical Director of the Washington Medical Coordination Center. So grateful to all of them. We have several panelists and presenters from previous phone calls in this series, and certainly grateful to them for joining us as well. The presentation will be started by Dr. Persoff and Dr. Bauman. Dr. Persoff, I'll go ahead and let you bring up your slides and go ahead and start.
All right, good morning, everybody. Really glad to have you guys here. I'm going to go ahead and start the presentation. And Karen, my astute partner, will go ahead and start us off. Karen, just let me know when you want me to advance the slides.
Great, thanks so much, Jason. And I'll pay you later for being the one to actually manage the slides. So as
we'll see about that first.
As Jeff had said, I'm Karen Baum. I'm from the University of Minnesota and mHealth Fairview. I'm a hospitalist and the vice president for system clinical operations within our health system. And this is, as mentioned, the third in a series. Today, we're going to be focusing on communication and coordination strategies, and really looking forward to the conversation after the slides, actually. So next slide. And again, for everybody's mental model, this is the third in a series. We discussed strategies and surge capacity, staffing and resilience, and then today, coordination and communication strategies. And with that, we'll talk about sort of three major themes during our short presentation today. The first is the need for deploying transparent and written protocols and processes. The second that we found both through literature review as well as work with our colleagues across the country and world is the need to work across traditional boundaries in order to achieve that communication and coordination effectively. And then finally, how we can all use technology, including social media, as an enabler rather than a barrier in these fairly trying times. And so with that, I'm going to hand this back to my colleague, Jason, who's going to talk about the first theme.
And my name is Jason Persoff. I'm from the University of Colorado Hospital. I'm the Assistant Director of Emergency Preparedness here. And so we're going to go ahead and start off talking about the idea that coordination of any communication strategy always begins locally. And when we think about the local control, this is traditionally done through the Hospital Incident Command System, or HICS, which came out of California as an expansion of the Incident Command System, which itself came out of California from forest fires many years ago. Command goals may not always align with clinical expectations of providers, and so a lot of providers often express dissatisfaction when there is an activation of a command center with the inability to access and coordinate with the upper level of command. All of our after-action reports for incidents occurring at the University of Colorado prior to 2015 listed the #1 problem was miscommunication as a root of dissatisfaction and also the cause of numerous problems. Knowing that when we activated our command center going into COVID, I thought it was very important that we build a position within the HICS structure. So let me talk about this briefly. At the very top, you notice the standard ICS structure with the command staff, including a med tech specialist in infectious disease. Under the operations section, the only physician position that actually was in place were both the ER branch director and the medical staff branch director for the hospital. We created a new position called the Physician Clinical Support Supervisor. This single person was responsible for a two-way communication and bridging the gap between the boots on the ground and command staff. Basically, the way this was broken down was every single unit, every single department or division was required to choose a representative from their group who would act as the person to pool all the information of concerns that they had or questions that they had, especially for our med tech specialists, and they would bring it to a daily meeting where all the other unit leaders from all the other divisions and departments would meet with the physician clinical support supervisor, who would then funnel those questions or concerns up to command. And then command would take those and run with them and then send them back to the physician clinical support supervisor for dissemination on a daily basis. The goal for these meetings was to make sure that everyone's needs were met and that there was clear and concise information transmission. One of the biggest problems we fought was, of course, rumors. Rumor mill was a big problem. And the benefit of this system was that it was able to quash rumors right where they started. The second thing was it was the first time that we had ever experienced in complete unity across the patient-facing side of our hospital through inpatient, outpatient, surgical, ER. Every single group was represented and had a voice in how we proceeded on a daily basis. There were various needs that needed to be met on both sides. The PCSS, the Physician Clinical Support Supervisor, acted both as a filter as well as an aggregator and a problem solver. While on the left, we had all the different things that the staff needed. On the right, everything that the administration needed to take care of. The PCSS acted as the main moderator to make sure that everyone's needs were met. Basically, the way this was constructed was there were daily meetings in the morning with the designated unit leaders from every
competitors working together to overcome barriers. And we placed over 500 patients thus far. And again, these are patients that sites and systems had already exhausted their normal referral patterns. So these were patients where, a small critical access hospital in northern Minnesota, yes, where it's -40 today, was really out of options. We are now expanding to med-surg as well. And then the third theme we wanted to talk about was how to use technology as an enabler instead of an extra barrier. Part of this is around reducing unnecessary documentation. Many of us have taken advantage of disaster documentation to reduce the amount of work that our nursing staff spends at the bedside. I think the challenge is going to be stopping that at the end of this and asking them to go back. The other large opportunity is to use technology around bed placement. On the right of the slide is an example from Washington, and I'm glad that we have representation from Steve today at how to use technology to know where your beds are, not only in your system, but across your whole state. And then finally, the opportunity to use media, including social media, to spread truth and to plan. For example, on the bottom middle is a screenshot of a COVID model that was developed and deployed throughout the country. It was actually used by 9 of our large health systems in our state to plan for the number of patients likely to be coming into our systems. And then on the bottom right is a screenshot of the vaccine dashboard that Brown recently deployed. Again, how do we pull large data sets together and get that information out there for everybody to use?
And in addition to that, the question is, how can we use social media to also quash rumors? Because as we've studied, and most of you are familiar, there is a contagion effect of misinformation. In fact, that can happen in a lot of different political and non-political ways. And in COVID, that was especially true, for example, with drugs such as hydroxychloroquine, where we were still awaiting data, and yet the information took off really rapidly. We've also compiled a list of references. I expect you all to sketch those down in the 2 seconds. I'm going to leave that up there. But just so that we get excellent reviews, we've also included a slide that shows puppies. And puppies is where we're going to leave it there. Thank you, guys.
Great presentation, both. Thank you, Jason. Thank you, Karen. I know from Henry Feldman to appreciate his input as well. At this point in time, what I'd like to do is, I know we have several panelists who have experiences to share as well and to comment. You know, Patty Masent, I know from CEO of UCSD Healthcare, we may not have you for the full hour as I understand it, so we want to give Patty a chance to share some of her experiences and to comment. So Patty, I'll go ahead and let you go ahead.
Great, thank you so much. And I've tried to clear things up so I can stay a little bit longer if it's helpful to all of you. And you know, as I look at the slides that were just showed, our experiences very similar to what the speakers have outlined. You know, we started our incident command center. It was actually February 5th, so a little over a year ago. Not that we're counting. Where you know, we had a conversation. I had a conversation with the county about taking the first patients from Wuhan, China, that were coming to Miramar, and we took those patients in and you know, immediately got our incident command center rolling. It was interesting because I remember I didn't actually go the first week at all, and I went the second week and went, well, I probably can't say that word, but oh my goodness, you know, we're going to need to really pick this up. We're really going to need to staff this up. This is not the standard nursing incident command center, although that's a super good structure to build off. It's a great chassis, but it needed to be much more than that. We needed to do massive process improvement. We needed to have a lot of engagement from all of our faculty leaders. We needed to create dashboards. We needed to improve processes. You know, very early on, we had a process issue that really came back to bite us. And so we brought in our transformational healthcare team, which is the team that does all the lean, you know, process improvement in our organization, to have them help us. We developed communication vehicles, and this team of incident command and all of the physicians and staff that are part of it, we still meet every day. There are times where we've backed off, you know, when the surges were not quite so great, because there's a lot of fatigue that happens. Okay, we didn't have one on Christmas Day or New Year's Day, but basically we run it every day. We've gotten it down to 15 minutes. We've got it scheduled so that we can get to the main issues. We've got teams doing all the process improvement outside and then reporting back. And this has been, to me, as I think about the last year, has really been the backbone of our success in managing the pandemic, is the fact that we have this one single point in time where everybody is focused, and we're driving to manage our patients, our surges, our vaccine, our testing, all the things that we've done through this one incident command vehicle, and it's been incredibly powerful. I do think, and not to pat myself on the back, but I do think the CEO's presence means that everyone shows up and is engaged too. And so, you could say, well, I need to be above it and I shouldn't be there. But number one, I really like it because I get a really quick snapshot on what's happening, but it also makes everybody show up, I think, in their best game, and gets everybody working together. And the last point, two other points. One is, I think it's really fostered a level of engagement, particularly of our faculty, that's been really powerful and incredible in teammanship with us, that they really feel engaged and involved in driving the decision making. Dr. Kranja's on the line. It's Dr. Kranja and her team that help us determine surge, crisis care standards. And we embrace those and really listen to our physician leaders, and they have a voice, and they can come every day with that voice to incident command, and we can listen and then respond accordingly. And the other point that was made is this has been a massive culture change relative to getting health systems to work together. And to be honest, the first month or two was a little bumpy. And there were, disagreements, and there were disagreements with the county, and, we had to work through those things. But I have to say today, and we're a very competitive market, that the CEOs and the CMOs are working incredibly closely together and incredibly supportive of each other. I think everyone kind of looks at managing the pandemic and getting the vaccine out there is really our imperative. And all of the competitive nature kind of falls away when you're really focused on something that's going to, really save the region. And so I think we have a structure where we were meeting weekly, we meet every other week depending on what's going on, but we do track all of the metrics that were shown in the previous slides, and it helps us really manage the region together. We share PPE, we share equipment. I have vents at Sharp right now. I've gotten things from Palomar. It just, we all are working together, and I think that's been really important.
Patty, it's Jeff Dichter here. One question I have for you: when you work with CEOs from other organizations, do you have a particular, an example in mind of how you guys faced a problem, were able to overcome those, the traditional boundaries, and be able to accomplish something that was of value to everybody?
Yeah, there are actually a lot, and it's not just, at least for our region, it's not just that we're working together, but we're also working hand in hand with our counties. So when we have our calls every week, we have not just the CEOs, but and sometimes the CMOs. The CMOs also meet on their own, but we also have the county there too. So for instance, when the county was figuring out the triggers for the phases, the CEOs were really involved in that process with our public health officer, and she didn't accept everything. And frankly, we didn't all agree on everything, but we all came together. And once, I have to say, once those decisions were made, we kept moving on and didn't go back and look at those again.
Thank you so much. Really, really grateful to hear those experiences. And I'd like to go ahead and ask, I know Kathy Stats and Krista Koenig are on, and both have worked closely with similar circumstances. And Kathy, I'd go ahead and turn it over to you, and go ahead, if you can comment on others and share your experiences with us.
Oh, for sure. Thank you so much. So it was helpful to see Minnesota's response. In many ways, it echoed our own experiences within California and Imperial County specifically. Rural county at the southernmost portion of California, right on the border with Mexico, San Diego counties, and Arizona. During California's first surge, we were one of the hardest hit areas of this state, and we are extremely resource limited. Prior to COVID, we had 22 ICU beds in the entire county and 160 beds. So in spite of increasing our capacity, 200%, we were still not able to keep up with the over 500,000 patients that we served in that area, including both our county and many of the US citizens and legal residents that lived just south of us in Mexico that would sometimes seek care within our county. By the end of that surge from May through July, we had transferred out over 600 patients out of the county, and that required significant logistical challenges and working through many different aspects. One of the most helpful and useful was a state organized transfer center with which we had daily phone calls. And as silly as it seems and as available as data should be, we found the only way to really get real-time data from all the important sources was daily phone calls with our hospitals, with our pre-hospital providers. We could also very much identify with you will be doing roles that you never imagined you would during disasters like this. As an EMS medical director, I don't think it's typically in the job description to be thinking about things like decedent management and repatriation, looking at pre-hospital providers in places they don't normally go, like SNFs, and helping with home health programs, which are both initiatives that significantly helped with our local capacity and able to move patients from within the hospital and sort of expedite their discharge so we could free up those hospital beds. And then finding areas where there were different bottlenecks, roles that we did not consider before, but for both hospitals, we found it was very helpful to have MDs, PAs, or NPs that would help coordinate which patients would potentially be able to be transferred out of hospital and speak directly with the state transfer center. Also was in very close communication with our neighbors, so having Dr. Christy Koenig on the call is helpful today because we were in almost daily conversations about ways to move patients. So those were some of the aspects that very much we can identify with Minnesota's experience and different ways that we worked through it.
And as I understand it from reading the popular media, Kathy, you guys were moving patients. It sounds like most of them went to San Diego, but they were going throughout the entire state of California, if I recall correct.
Our peak, we had no ICU beds within our county that were available. We had patients boarding in our emergency department for greater than 3 days, some greater than 7 days, very, very ill ICU patients. So when we had ICU beds that became available throughout the state, we took them. Some patients traveled as far as over 600 miles to Sacramento. Of the over 600 patients that were transported out, over half of them were transported by air providers. Majority were helicoptered to our local surrounding counties, which are San Diego and Riverside, but we did also use fixed wing. And I could give a whole long talk about the challenges of air transport during COVID, including the logistics of oxygen limitations, both oxygen regulators freezing as well as running out because patients are requiring such high flow rates. So having our air ambulance agencies also working together when often it is less of a potentially collaborative space, but everyone has really come together to do a great job to care for our patients in the county.
Dr. Statz, if I could add, if you don't mind, part of what happened when we received those first patients from Wuhan was, we have an affiliation with El Centro Regional Medical Center, and I got on the phone with the CEO there and said, this is going to be a huge problem. At that point, there was hardly any critical care capacity out there. There wasn't 24/7 critical care capacity at all. And we launched a tele-critical care service to support, and then ultimately got boots on the ground. But it was a huge stretch. And I can't remember, Dr. Statz might know the exact number, from basically not having 24/7 critical care to, there's, I don't know, maybe 36 to 40 critical care beds available now and more.
Absolutely. No, it's been incredible to support the two hospitals we have in our region. They are both associated with fantastic organizations in San Diego County. So Scripps and UCSD were absolutely pivotal to the response as well. So we do have now over 40 ICU available beds, which doubled the county's overall capacity just at one hospital.
And remember that Imperial County is right on the border with Mexico, so there are also patients coming across the border, and talk about low resources. There were low resources on the other side of the border as well.
And Christy, were there any other pearls that I know you've shared with the task force along the way? Is there anything else you'd want to share for this purposes here today, that other experiences that you feel are valuable?
Sure, thank you so much, Jeff. And I want to support what Patty said in a couple of points. First of all, the opportunity for us in San Diego to host the Wuhan repatriates at a military federal quarantine site really gave us the opportunity to practice our systems without it going widespread across the whole county. So get that ICS up and running, get the EMS transport, deal with the media who wanted to watch people dressed up in moon suits transporting patients back and forth. And so that was really actually very valuable as sort of a practice run. And also the collaboration in San Diego, I think, is really unique. We have 20 some odd acute care hospitals, different healthcare systems normally who are in competition, who were all collaborating to an amazing, amazing degree. I've not seen that elsewhere. One thing I'll mention about the incident command system is that traditionally, if you look at disasters in the US, it's often not a lack of resources, but a lack of a communications and coordination system to coordinate those resources. In fact, sometimes you have more resources than you need, but you can't get them to the right place at the right time. So I think the ICS structure, and now being used in healthcare, is really one of the most important aspects of managing a disaster. And the final thing I'll say, I put a little bit in the chat, is this is very unique because most of us who are involved in the ICS functions are also still doing our day jobs. And ideally what you want is you want somebody who goes and works their shift and performs their function within the ICS structure, and somebody else is taking care of the regular patients and the day-to-day activities. And there's a completely different reporting structure, right? You have a boss in your day job, but you report to someone else in ICS. And sometimes people don't understand those organizational structures. So that, I think, has been extremely challenging, in addition to the fact that this has been going on for over a year. Thank you.
Thanks, Christy. Steve Mitchell, we're going to hear from you from the University of Washington next. And if we could do the audience response questions to follow from that, Amanda. And Rick, if there are questions from the audience, if we could have those, if you wouldn't mind taking a look and seeing if there are the good ones there. And the other panelists will have a chance after Steve in the audience response too. Steve Mitchell, go ahead, please.
Thanks, everybody. I really appreciate everybody's comments. And Christy, I completely identify with what you've been talking about, with trying to work your day job as well as work within the ICS structure, and also using the incident command structure to and a coordination structure to be able to match resources to where they are needed, because we've certainly all learned in this pandemic that outbreaks happen. They do happen over wide areas, but they most often happen in geographically specific areas or targeted areas. And so I'm a huge advocate for trying to build a structure where you can coordinate things over a large geographic region, so that when certain towns or cities or hospitals are hit, then you can offload them, bring the resources to them, or offload them to different areas that have capacity. And so in the Washington State experience, we learned quite early on with the single nursing home overwhelming a single really well-run hospital that we were going to have to completely rethink everything. And so from the beginning, we started realizing that it had to be over a large geographic region. At first, we took our disaster structure out of ESF8 and applied it, and then to just Western Washington, and then eventually when the state came to us, we have been coordinating activity over our entire state. a big part of our work, 60% of our work, has been really in service to the critical access hospitals. I can't remember, I think it was Karen who mentioned early on that, one of our early targets was that critical access hospital who is really out of resources and who is overwhelmed and has no options. They are powerless in the situation. And so 60% of our work has been serving those folks when their usual transfer patterns have been exhausted. And then our coordination center would then work with a statewide platform that we established to then place the patient in the system that we knew from the data platforms still has some sort of capacity. A key point that we learned early on also is that, as mentioned, we had to work across systems, across normal competitors, and really there was great work with our hospital association, our healthcare coalitions, and all levels of government to really mandate, and it led to a signed agreement with every chief executive in our state that said, here's how we're going to operationalize this, and here's our philosophical goals, and here's how we're going to operationalize this. I would say the authority, but we tried not to use that heavy-handedness in our work. But when we were called in to try and move patients, the places that we were calling they could not refuse us unless a senior person within that hospital or health system was made aware. And then, of course, which is so important, there had to be widespread accountability. So we would report out, here's what our activity was. And a few times we said, here's who's saying yes consistently, and here's a few times that people have said no. And that sort of level of accountability kind of furthered our work. And then we published widely or sent out widely kind of our decision-making philosophy and how we would approach things, our commitment to people, and our accountability and our QA process. And that seems to have been effective. We are fortunate in that we haven't moved the extremely large numbers of patients that Minnesota has, and California certainly, but we're really pleased with the structure that will outlive the pandemic. And so I'll go ahead and stop there for now.
Thank you, Steve. Appreciate it. And one of the things that I hear across all of them was the fact that we're building new structures that we haven't used before, that there's a certain commitment to cooperation across the areas and a certain support for the empowerment. Empowerment's a term that resonated when I would listen to you talk about being able to have the coordination center, being able to really effectively move patients with the cooperation of all the hospitals and systems they had to deal with. Amanda, why don't we go ahead and do the three, I think we have three audience response questions, and then we'll open it up. So question number one, when thinking about frontline clinicians, how open was transparent two-way communication with your incident command of your hospital or health system to ensure everyone's needs or concerns were being met? Were you connected to them? Did you understand what was happening? And so the answers are frontline clinicians had clear two-way communication with the incident command. Only department leaders had two-way communication with incident command. Only hospital leaders had it with command. And then our hospital did not use, or it was not apparent to frontline clinicians, the incident command structure. So go ahead and answer those, please. All right, another couple of seconds here, another 5 seconds. Okay, so we'll go ahead and close that out there. And it looks like it's really spread all the way across the structure here, where frontline clinicians really were in the loop to where it was really just mainly leadership were in the loop with this. So let's go ahead and go to the next question, Amanda. Does your hospital system have a clear written triage mechanisms to coordinate patient placement and or supply sharing ventilators? In other words, do you have a system or a mechanism, a process to move things like ventilators, ECMO, patient beds across your hospitals and health systems? So the answers are yes, within our hospital or health system only, yes, regionally or within local healthcare coalitions, so beyond your own health system, yes, statewide, or no, there are no sharing mechanisms, or if you're not sure. And we'll let this go another 10 seconds or so. So at this point, looking at it, I would say the one thing that resonates with me is almost half, 45% was not aware of any such mechanisms. 13% said no, so that's about 60% right there. About 18% had their be able to have a process to move things within the system. Some 15% within the region, and only 8% within the state. Let's go ahead and go to the next question, please, Amanda. So question number 3, is there a transparent mechanism, i.e. specific triggers to open and expand, or on the flip side, to demobilize your hospital or health system emergency operations center? Was it clear when it was set up and why, and when it was able to be brought back down? So the answers are yes, no, or you're not sure. So we'll give everybody another few seconds here to go ahead and answer. Five more seconds here. So looking at the answers, maybe a third felt that they knew that there was a mechanism for this. About 18% did not know, and probably half were unsure. And so I think, Jason, listening to your part of this, your presentation resonates with me that I think an awful lot of people were unaware of their incident command structures, or what was happening when it was going up or when it was going down. All right, thank you. Thank you, Amanda. I think those are all of our audience response questions. Rick, do you have anything from the chat that you can share from the audience?
Yeah, one just popped up about it's the concept of bed availability and the ICS system, including hospitals and healthcare systems in the bordering states. And they used the example in their state, they included facilities outside of the state in their trauma system. And during the pandemic, they added it for critical care beds for medical admission needs. And, you know, the obvious, some of those facilities might have shorter transport times and shorter travel distance for their families. So the question about like encompassing the ICS system to be inclusive of other states.
Did anybody have experience? Most of these things are set up at a state level, but did others have experience transporting across state lines? Were there any issues or concerns or experiences to be shared?
Well, that's the whole idea of the National Disaster Medical System, right? Is it's supposed to be, if you have a disaster that affects one part of the country and another part is relatively preserved, which didn't always apply during this disaster, you would transport patients across state lines by activating the patient movement portion of NDMS. But we didn't really do that for this particular disaster, even though there were times when that probably could have worked. Part of the issue is that system was not conceived for a situation where patients are contagious, because that's a whole different spectrum of transport if you've got somebody with a contagious infectious disease. But that's what it was originally set up for, with a sort of a catastrophic earthquake in the Midwest scenario and moving patients across state lines.
Our system was different. I know what you're referring to, but in Ohio, this was years ago, because of the vicinities with West Virginia and Kentucky, we already incorporated them officially as part of our trauma system. So without involving the feds with this disaster, we've collaborated with those hospitals for ICU bed capacity so that we don't have to activate a national system to do that. I was just curious if that was the case in Minnesota.
Yeah, I mean, it was actually sort of an interesting this was all an interesting adventure in the sense that I never want to have this adventure again. But we have always taken some patients across state lines, just because, like you said, like Eastern North Dakota, it's actually closer for the patient sometimes to come to the Twin Cities, right? For very specialty care. For example, there's no ECMO in North Dakota, none. So, you have to be able to transport patients across those lines. And so we sort of bolted on to processes we already had in place, if that makes sense.
Yeah, I wasn't so much referring to transport, but also just reporting of bed capacity. That's what we've been doing.
And we did
We
that.
always do.
So yeah, so our daily calls, we had representatives from the large health systems in North Dakota as well. And in fact, North Dakota caught wind of what we did, initially sort of talked to us about whether or not we'd take on bed placement for North Dakota. I politely declined. And but where there is now a process in North Dakota that's modeled after ours, which we are connected with, that's run by Essentia Health Systems, which has hospitals in both Minnesota and North Dakota. And so that's the thing, right? I mean, you don't build a wall around your state. It's not how it works.
Yeah, Karen, thank you. Your last comment reminded me of the disasters don't quite pay attention to the borders. And if ever there was a circumstance in a century that exemplified that, I think it's like now. So yeah, it's the concept of our hospitals across the state borders working with each other. That's sort of like the bottom line. The Jeff, a question maybe actually for you, or the group it's like one of those far reach kind of existential, almost philosophical question, but I think it's an important one. Anyone who's done anything in the world of disaster medicine, even though we don't have a discipline of that, and policymakers are pretty forthcoming in admitting, the short memory spans, and one. It's at least clear from our polling during, I think we've got like 100, this might be rounds number 118, that people are really tired and like spread to like throw down their stethoscopes, like I'm done with this, and we got that. And yet it's interesting in the chat to see, and also some of the comments made. I think Steve, you made a really important comment about long-lasting positive outcomes because of this, or relationships built. And so how is it that the work that's been done by the critical care community, and I got to tell you, as being disaster chief for 2 large academic medical centers, I never saw an ICU doc in any of the disaster committee meetings. That clearly that's changed. Clearly that's changed. But how is it that your not just your group, but the critical care community really embed this as not just institutional knowledge, but part of the culture? I'm thinking about your fellows, I'm thinking about the residents, the medical students that are coming through, so that 3 decades from now, God forbid we have another one and we're all not here, that some of this doesn't have to get redone.
It's really, I smile a little when you ask that, Rick, because this has been one of the things that we wrestle with all the time. How do we build a culture of disaster preparedness? One of the lessons we've learned, I'll back up, is that if disaster preparedness doesn't feel like it's part of your usual, what you do day to day, it often isn't something you can just dust off a shelf once a year or once every 10 years to use. So when we build critical care, there's a couple of philosophies that we build upon as a critical care task force. And number one is that ideally when we recommend care and we do research and we publish papers and whatnot, or give talks, is that it should feel as close to what people normally do as it possibly can. So that's one of the principles that we've learned, so that it doesn't feel different, it just feels more so. And the other thing that we've learned in the critical care community is that critical care is not an ICU. Critical care is wherever critical care needs to be delivered. That's the emergency room. It's by EMS in the field. It's hospitalists in the ward settings. it's a lot of different places. So we've tried to focus on the delivery of critical care by those who are at the point of care at the moment that it's needed. So trying to really, and this use as an emergency medicine physician, Jason and Karen are both hospitalists who are obviously very experienced with this. And I hopefully I don't insult anybody else on the phone call. But that's one of the other principles. And the last principle that we've learned, which may not be as quite as pointed for this pandemic, is that we always include pediatrics, because pediatrics are 25% of our population, and in a mass disaster, kids are involved. And so how do we help manage them within the resources we have appropriately and responsibly? So those are some of the things that when we look at this pandemic, we're trying to learn and trying to help assimilate the tools that worked for this pandemic. We also worry a little bit because although we hope we're on the downslide now to the end, one of my colleagues from the University of Minnesota, Mike Osterholm, you've all seen on the news, is convinced, and others are too, that we may yet have another wave due to variants, which gets back to the beginning of the call. Rick, your concern, which is very valid, and trying to get information on that with the crowdsourcing question. So what we're trying to do is just, I guess that's a long answer to just say we're trying to learn as much as we can from each other from forums like this. So with the next time we build standards of care, they'll be inclusive of this, they'll be informed by this, and they'll be more structurally sound as we move forward. One question that I would have I know Kelly and Lindsay are both here from New York City. Vikram has shared from us, the health systems are big there. They've all learned to work together. Do you guys have any experience where health systems worked across health systems with other health systems during your surge?
I can tell you, and Lindsay can probably speak even more to this than I can, but I can tell you, and it's one of the things that I mentioned in the chat, is that certainly in our first surge in last spring, ICU clinician really so focused on the patients in front of me. I actually had no idea that our New York Presbyterian system, we were so busy with our own, 7 or 9 or whatever it is, hospitals, and trying to accommodate transfers and supplies and equipment among those within our own system. I had no understanding or appreciation of collaboration and communication between the other hospital systems in New York. As it turns out, and I only know this because I specifically asked, our CEO and the CEOs of all the New York systems, starting then and continuing through this entire year, speak almost daily and discuss, needs and shortages and equipment and supplies and so on. We haven't, except in very rare occasions, again, refresh my memory, but we have not routinely moved patients from outside our own NYP broad institution just because we've been absolutely swamped within our own hospital system. But there's, one of the things I mentioned in the chat, like I said, is making sure your clinicians and your people below the leadership level really have some understanding of what's going on. And I think people didn't want to kind of bother us with information that they didn't think was necessary, but it is so distressing to see neighboring hospitals and your colleagues and patients in your city really struggling and feel like, maybe if you're in a resourced facility that you're not doing everything that you can to help, and to know that there is that ongoing, communication and attempts at collaboration is happening. I think that in its own right is valuable, even if we're not, speaking on a day-to-day level with our peers and our colleagues at the clinical level. Right, Linz, do you have anything to add?
No, I agree. I mean, I think, like you said, the hospital systems here are very large, including the city's health and hospitals. And I think because each system has such a large, sort of diverse group of hospitals, each system, although they were speaking at the high levels, really was just load balancing within their own system. And in fact, when our numbers are tight, we are directed not to take anybody from another system without COO approval. So occasionally it will happen. We get a request from a hospital in another system, and we normally accept all transfers within. We'll have to escalate that to leadership, because generally they are sort of the ones who know what's going on with the other systems, and they'll tell us if there's a reason we should be accepting from outside our system.
There's so many more questions I think that looking around, people would like to ask and learn from each other. We're at the top of the hour right now, so we're going to have to close this, which is really disappointing for all of us, for me personally. But we do, and I'm going to turn it, Bruce Drumminger, I'm going to turn it back to you. Thank you. And I'm grateful to all of our panelists, all of our presenters. Wonderful conversation, and I'm hopeful that we will be able to revisit this at some point soon again. Thank you.
Thank you, Jeff, and thanks to everyone for a really dynamic, wonderful, interactive dialogue. One of the most interactive I think we've seen in a long time. So thanks. Hoping everyone also who's joined us today can take 2 or 3 minutes and complete the quick survey to get your continuing education credits and help us improve what we're doing here and inform what you want to learn about in the future. Rick, any final words from you before we sign off for today?
Look, just thanks to our participants, like really robust comments in the chat, and appreciate the crowdsourced responses. Yeah, we're trying to get like a beginning handle of what today is, because today is not March 2020 by a long shot. And then to our panelists, I agree, Bruce, really extraordinary discussion with a lot of people. And then to the task force, wow. Jeff, I remember when Jeff proposed a series to us, and sort of like, well, let's wing it, give it a try, because you know, could be a great contribution. The 3 series, or the series of 3, has really been extraordinarily helpful in our peer-to-peer learning here. So to the panelists, our presenters, and Jeff, your leadership with the task force in pulling this off, deeply grateful, and stay tuned for more to come. With that, thanks all, and goodbye.
Thanks, everyone.
Thanks, Rick. Thanks, Bruce. Bye now, everybody.